Folks, welcome to the Royal College of Surgeons of Edinburgh's Regional Surgical Advisors webinar series for medical undergraduates. Most of you must know that the Royal College of Surgeons of Edinburgh is the first and the oldest surgical college in the world, having more than 500 years of being in the forefront of setting standards for surgery. You will soon also come to know that we are reputed to being the most inclusive and friendliest. And with the disruption of the functioning of medical schools, our aim is to provide a focus of regular teaching with bi-weekly webinars to augment distance learning you might already be having. These webinars are unique in as much as they, unlike other webinars, are freely accessible to whoever registers, and one does not need to be an affiliate member or a fellow to do so. We want all of you to benefit with this facility. And today's topic, Aids to Approaching the Acute Abdomen, is presented by Mr. Giles Bond-Smith, Consultant Emergency and HPB Surgeon at Oxford. He is ideal to kick off this set of webinars and teaching. He's the clinical lead for emergency general surgery at Oxford, and he's in the forefront of developing emergency general surgery in Oxford and in UK, being a founder member and a key figure in the National Forum for Acute Surgery. So without much ado, I'd like Giles to start off, but I will continue to moderate and take questions on the Q&A facility on Zoom, which we will go to later. Over to you, Giles.
Hey, Mike, thanks very much. I'll share my presentation now with hopefully everybody. They can see that. Thanks for giving me the opportunity on behalf of the Royal College of Surgeons of Edinburgh to present. This is an undergraduate talk, basically aimed at taking out the anxiety of seeing an acute surgical patient with an acute abdomen and coming up with a differential diagnosis and ultimately narrowing down that differential diagnosis to the correct diagnosis. So I gave a deliberately vague scenario, which is typically the kind of thing that A&E, ED will hand over. Yeah, I've got an 18-year-old female, generalized abdominal pain. It's in the right iliac fossa. Clearly, the only answer here is it's appendicitis. Obs and gynae have refused to see the patient until any sort of appendix problem has been sort of ruled out. And hence you've got to see the patient. So as the sort of F1 running down, which I know you'll all do, to see the patient, you know, what are your initial thoughts here? You've got to take a history. God, I've got to think of all my surgical sieves. What do I include in the history? I've got to do a clinical examination. Oh, I haven't done that since finals. Do I always need to do a PR? What bedside observations will be available to me? What simple near-patient tests? Can I get the urinalysis? Can I get blood tests immediately, or do I have to send them off to the lab? And at the end of the day, what on earth's my differential diagnosis going to be? So when I present the patient to my senior, you know, I've got to come up with something sensible. And that is really anxiety-provoking. And one of the ways that I thought I'd just try and flip this round to make it a bit easier is if you could walk down to ED to go and see the patient with a differential diagnosis that was very long. Now, if we go back to that original scenario, I suspect most of you have come up with between anywhere from sort of 10 to 15, maybe a bit more differential diagnoses. And hopefully by the end of this, what you will have is a differential diagnosis list that would be 50 to 60, maybe a lot more in your differential diagnosis list. In your mind, before you've even started to get down to the patient, then you can use your history skills to knock out all those differential diagnoses, and then your clinical examination helps you knock out further, the bedside observations, further still, and then tests, narrow it right down so you get an absolute cracking diagnosis at the end of it. So what are we talking about here? If you look at the abdomen, I'm sure you all know that there's 9 quadrants to the abdomen. Right hypochondrium, epigastric, left hypochondrium, right lumbar, the umbilical region, left lumbar, right iliac fossa, hypogastrium, left iliac fossa. But what we mustn't forget are 2 other regions, and that is above the diaphragm and also below the inguinal ligaments and the genitalia. So, given that scenario, and I'm going to try and link this short lecture just about that scenario, where can we start? Well, let's just take the appendix. Oh, sorry, before I go on there, if you look at that, those squares, those quadrants, the first rule is that you need to localize where is the pain maximally. So if it's in the right iliac fossa, you're able to borrow differential diagnoses from the suprapubic region, the right lumbar, and the umbilical region. You're allowed to do that, right? So it's not just about what's in the right iliac fossa, it's quadrants that are adjacent or diagonal, which is why we really don't like umbilical pain. It's just very difficult to really pin down what is going on, unless of course you feel a big pulsating mass in that area. The second rule, as I was about to go and say, is it's all about the abdominal anatomy. So what are we going to talk about? Well, what are we going to first thoughts? In an 18-year-old female, look, let's just talk about the appendix. Most of you will have come up with appendicitis. But will you have thought about the oma? And this is a third really, really simple rule. You can add itis and oma to any structure in the abdomen and effectively get multiple differential diagnoses. So right iliac fossa pain is not just about appendicitis, it's also about the ependymoma, the appendiceal cancer. Then within that, you can start being a bit more clever and start thinking, well, what types of cancer are likely to be there? The appendix, epithelial line structure. Number 1 you'd be thinking about is an adenocarcinoma type. Maybe some of you have thought, actually I've heard of the neuroendocrine tumors, the carcinoids, which, you know what, they do present in exactly the same way as appendicitis. Why is that important? Because look at your history now. Now you'd be asking things like, have you had change in bowel habit? Very rarely, NETs in the appendix can present with sort of carcinoid syndrome. It's less than 1%, but it can do. So is the patient flushing? Are they getting loss of appetite, weight loss, all these problems? If the answer is no, 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 then what you're doing is you are knocking out the malignant, the oma side of your differential diagnosis. So if we take the next structure to the appendix and think about the cecum, then it works well. You've obviously got cecal tumor. So maybe it's not an 18-year-old female, but it's a 56-year-old male that's come in. You would be worried, especially on a background of weight loss, change in bowel habit, all of which you're now adding into your history to try and limit down your differential diagnosis. You can sort of, are they high risk, low risk for having an oma rather than an itis pathology? But some of you may also, you can then add in to the cecum, cecitis. I mean, have we ever heard of that? I mean, it's a word. Typhlitis is the more commonly used name, and that's sort of a great diagnosis to make. Maybe the patient's recently been on chemotherapy or something like that, and they've got neutropenia. That is a different patient to the 18-year-old coming in. It's a different patient to the appendicitis type patient. So again, your history, given your long list of differential diagnoses that you're making, you can use your history to just knock these cases out. Moving around, you've got the colon. Well, obviously there's the omas with the colon, but then there's the itis, colitis. But here you can get even more differential diagnoses, because it's not just about colitis, is it? It's about what type of colitis. Is it infective? Is it ischemic? Is it inflammatory? And if it's infective, is it bacterial? Is it viral? Do you see where I'm going? So has the patient had any recent foreign travel? Have they been in contact with other people that have been unwell? Have they been on any medication, antibiotics that have created abnormal gut flora leading to a sort of infective colitis? Maybe the patient is a really heavy smoker, and even though that they're young, they've got microvascular disease and they're developing early ischemic colitis. So you can move round the abdomen, doing itis and oma to all these structures. There's another rule. Luminal structures, you get 3 differential diagnoses for each luminal structures, because you get a differential for one in the lumen, one within the wall of the structure, and one for something out pushing in. So it's in, within, and out to try and help you build up that initial differential diagnosis that you're going to use your history to knock out. So let's just take the ureter, because I know you're all thinking about that. What's the most likely within the lumen? Ureteric stone. So now you'd be asking about any change in urinary habit, any blood. Then you'd be thinking, I need to get a urinalysis and start looking at, is there any hematuria? Is the urinalysis abnormal in any way? Within the wall, is there a urothelioma of some sort going on? So again, is this a chronic pain, not a chronic pain? Has it started recently? Is there any family history of problems? Again, any sinister symptoms within the urology type history part of your history taking? And what about the out pushing in? Well, it's not just the cecal tumor that pushes on the ureter, but loads of things. But let's not forget the retroperitoneal sarcoma. I mean, how great to pick up in your differential diagnosis to take a really accurate history, come up and say, actually, I don't think that this 18-year-old is a straightforward appendicitis. I think actually, given that in the history I've picked up some urinary symptoms, which are obstructive in pathology, I worry that there's something else going on. And that's where your history really, really comes in and is important. Luminal structures, don't forget about blood vessels. So in the right iliac fossa, you've got your iliac artery, which again, you can have things in, within, and out, pushing in on the structure to help you with the diagnosis. And obviously, blood vessels dissect, tear, or they can become aneurysmal and rupture. And people do present with right iliac fossa pain, and it's some sort of blood vessel related pathology. Again, in your history, have you had anything related to that? Any recent procedures in the groin, any IR, etc., etc.? You know, patients do come in post-procedure with these problems, and it's not always just appendicitis. It's a female in this case, so we mustn't forget all about the gynecology apparatus. But again, it's not just ectopic pregnancy, ovarian cyst. We can add oma to all of these things. So you get your endometrial sort of omas, fibroids, etc., which can present in this way. And you also get uritis, so you can get salpingitis, etc., etc., PID. Again, we would change our history, be asking our history to try and knock out, have you had any vaginal discharge or gynecological related symptoms? Said that very badly. Gynecological related symptoms. We mustn't forget the differences between male and female. And as I've said, just in the don't forget, you've got all the gynecology anatomy there, but don't forget things, bones, osteomyelitis in the slightly older patient. Maybe the 18-year-old actually had mild appendicitis, which has just been grumbling away, created a psoas abscess, which is tracked down and then ended up causing a sort of degree of osteomyelitis. I mean, that's when you start talking about any problems mobilizing and moving your hip, etc., etc. I doubt that many of you would have thought in that detail in taking your history or seeing the relevance, but what you're doing is you're knocking out every single possible one of your massive long differential diagnosis, narrowing it down to the few. Don't forget about above the diaphragm. Pneumonias can present as sort of right upper quadrant pain, as can cardiac disease, and also below the inguinal ligament. That can also present as right iliac fossa, left iliac fossa pain. So have a look into the groins. Are there lymph nodes? Are there saphenopharynx? Are there problems below the inguinal ligament that you can ask about in your history? Maybe the patient's got right iliac fossa pain and a small little abscess in the right groin. Are you worried that that's a groin abscess, or is it a psoas abscess that's tracked down and come underneath the ligament? And at the end of all of this, in your massive long surgical list, don't forget about the medical causes. So TB, et cetera, that can present with abdominal pain. So to go right back, I think if we go other things, we mustn't forget lymphatics. So if we think about in the abdomen, right iliac fossa pain, what lymphatic problems can you get there? Well, there's lymph nodes in and around the appendix. So mesenteric adenitis, that's a lymphatic problem. What about lymphoma? And that's just going purely itis, oma, and thinking about the lymphatic system in that area. Think about the abdominal wall. There's muscles, fat, skin, lumps and bumps, all of which should be talked about in your history to limit down your differential diagnosis. So your history should reduce your long list by about 80 to 90%. It's really important. Then you go and do your clinical examination and it's focused. Your clinical examination should be done in a systematic manner to support what is now a much shorter differential diagnosis. Roth-Singh's, is it positive? Yes or no? Murphy's sign, is it there? Thinking about pancreatitis. Think about all the other different types of clinical signs you can feel in the abdomen, all of which are now relevant to the history that you've taken to shorten your long list down to a short differential. And then, very topical, test. Having got down, what are you going to do? Get some observations, get urinalysis, check the pregnancy. Blood tests, I've written down there, full blood count, UZNEs, LFTs. All of these are now targeted, not just because you're randomly ordering them, but they're helping you limit your differential diagnosis. And given all of those, then you can work up your radiology if it's appropriate, starting with simple X-rays, moving up to ultrasound, CTs, MRs, and then onto the really complex stuff. But by the time you're ordering that complex stuff, your boss will be really impressed with your differential and the fact that you've come up with a really sensible diagnosis, or at least a differential diagnosis comprising 3 or 4 really good diagnoses. So now, when you look at that scenario, it's vague, it's deliberately vague. That's the kind of thing that you get from ED. As you're walking down, you're not going to be panicked like that baby in the sort of second slide. You're going to be thinking to create your huge differential diagnosis. You're then going to use your history to systematically knock out all those differentials to get down to a nice short list. And then you use your tests to absolutely confirm your diagnosis. If you follow this with all your surgical sieves and everything, you're going to absolutely smash to any surgical abdomen. It will be, you will really, really do well. I was given 20 minutes. I think that's 19 minutes. It's a huge subject, but hopefully the 4 rules in there should be useful for you guys just to really do well in your first time as working as an F1. I thank you. Mike, I hope that was all right.
Brilliant, Rafat. Thank you. We've got some questions rolling in.
Yeah.
And I wonder whether we could take them. Stefanos had asked, how common is it for colorectal tumors to present with abdominal pain?
Interesting. So they do present with abdominal pain, but they typically, the reason they're presenting with abdominal pain is because they're creating a secondary problem. So they're either nearly obstructing or fully obstructing. That's a great way to sort of pick up a sort of colorectal type pathology. But you know what? They may present with just PR bleeding. So the typical patient, the elderly person who comes in with first-time PR bleeding, now your history is asking more about weight loss. Is there mucus associated with it? Is it bright red blood? Is it dark red blood? To try and get a feel for, is this a lower GI bleed, upper GI bleed, or right-sided bleed? But yeah, they do, and your history will point you in the right direction. But again, what are you going to do? Take your history, do a clinical examination, work up the tests. You can start doing tumor markers. They're going to take a while to come back, so they're not going to help you in the acute stage necessarily. But then when you do an X-ray, and let's just say the patient's presented with subacute bowel obstruction or actually frank bowel obstruction, you're going to see that on the X-ray and move sensibly onto a CT, having discussed with one of your seniors.
Excellent, Giles. And that takes me back to what you emphasized so eloquently, and that is that the history is as important as your differential diagnosis. Because we've had a few questions as to how one narrows down to the pertinent ones that you need to consider, and common things being common. You've been talking about a few fairly obscure causes as well. Yeah. And that's the importance of having the obscure causes in the back of your mind, but knowing when to home in onto them. And that's what's important, isn't it?
It is really important. Common things are common. And this is where experience comes into play. If you take a good history every time with that long differential, you will find your history skills knock out down to the same few differentials on the majority of time. So it will be appendicitis, ovarian pathology, endometrial uterine pathology, Crohn's, or whatever it's going to be. It will be that the majority of the time. What I'm trying to say is that if you have that long differential, you won't forget about the slightly rarer causes. And that's really, really important. And it's really annoying when a consultant walks in and comes out with a great diagnosis, which is absolutely correct after answering one question, after asking only one question. And the reason a consultant can do that is because he's heard the history 3 or 4 different times, and he's got benefit of some blood tests, may not have seen any imaging, but in his mind, he's narrowed it down to just 2 or 3 things. One question, that's how he gets the diagnosis. It's not that there's some magic behind it. But common things are common. The more you do, the better you'll get at working out what's common and what's not.
And we've got an interesting question, Giles, from Jayapala, who said, as it is an acute abdomen, and if the patient's hemodynamically unstable, what next? Bothering about OMAs in acute abdomen is not wise, I feel. And I agree with him, but that's exactly what you've been trying to emphasize. It's the history that needs to be tied up with your differential diagnosis. So if you've got a patient who's hemodynamically unstable, you certainly wouldn't be considering OMAs unless there has been a bleed from a tumor, which again is relevant.
Correct. I'd agree with that.
And we've got a question from Stephanie, who again is asking about the relevance of having a gynecological problem and whether the patient should have been referred on to gynecology first. So just to read out her question, would the female patient always be referred to surgery before obs and gynae, or does it depend on where the pain is? If I was a F1 and the patient complained the pain was in the hypogastric region, would I be more inclined to refer the patient to obs and gynae first? I think the history is important first, isn't it?
Of course it is. I mean, look, straight out, you can just ask the question, is the patient pregnant, yes or no? Because ED typically do pregnancy tests really quickly. So is the patient pregnant? Yes. How many weeks are they pregnant? 7. Is there any PV bleeding? Yes. Clearly, that is going to head towards obs-and-gynae as a possible ectopic rather than this is an appendicitis. But at the end of the day, I cannot stress this enough. There is a patient there. And it is our duty to see and treat that patient as quickly as possible. So saying to ED, I'll refer on to obs-and-gynae, and it turns out that obs-and-gynae are just beginning a 4-hour case, it is much better for us to proactively go down, see the patient, exclude a surgical pathology, and then safely refer the patient on to obs-and-gynae as needed. We are desperately trying to stop this ping pong, refer to them, refer to us, refer to them, refer to us, and ED get caught in the middle. Don't do that. Ask some sensible questions. If they're negative and you feel, actually, I'm just going to see the patient, head straight down, see the patient. It's much, much quicker in the long run.
Excellent. I think we've got time just for a couple more questions. And I've got another one. Are there any go-to tests that should always be ordered in the context of acute abdomen in the first instance, other than for pregnancy test in women?
Interesting, isn't it? Do you know what? I don't like the, I've never really liked that always do this, always order that. I know we do a lot of things.
And I think that's related to the fact that nothing's written in stone in medicine or surgery.
Correct.
There's always
room for something, isn't there? That's the problem. And your history will steer you into the right direction. This 18-year-old girl with right iliac fossa pain, if you're having a difficulty differentiating between appendicitis or ovarian pathology, you're going to be getting an ultrasound. But let's just say it was a 56-year-old lady, similar sort of story, and you're still finding it difficult. You're probably going to be pushing for a CT, because in that age group, you're worried that there's something more going on. And I mean that in a sort of more OMA or malignant process, or a bit more complex appendicitis. Maybe that 18-year-old girl actually has been having symptoms for a week, treated with antibiotics for a GP, and when you do the clinical examination, you can feel a mass. Then you may be thinking about CT, you'll probably get blip, she's 18, moving to an MR. So there's nothing written in stone. It's about having the appropriate test for the patient. And that comes from your history.
We've got a question from Alice Giles asking, are there any tips in distinguishing between perforation and obstruction? And I think that lends on to our next webinar perfectly, because we're having...
There we go.
We're having another one coming to you next Tuesday at 4 p.m. Same format. And we've got one of our colorectal surgeons who's a regional surgical advisor who's going to be talking to you about the management of intestinal obstruction. So I think there will be a touching on the history and examination in that case as well. So I think this is just to make you more interested in maybe keeping that time free. And we'll follow that on with another one on Thursday next week. And we've got a question from another attendee asking whether there'll be access to slides used at this presentation. Yes, they are, and it's through the website. There's a link that you can access them to. There are lots of other questions, but I think we're nearly out of time. So
just to
wrap up, Giles, you can have the final say.
Mike, thanks very much. History is key. The history absolutely helps you in 80 to 90% of your diagnosis. And just have that structure. ITIS, OMA, in, within, out. Think about your patient bedside tests and then work your way up. You guys, never be afraid to ask and always be proactive. Thanks,
So
Mike.
we're planning on having 2 of these webinars each week at the same time, 4 p.m., Tuesdays and Thursdays. Join us. We'll have some general surgical topics to start with, and then we're going on to the subspecialties and moving through as much as we can do. And depending on attendance, we might even extend things. Have a nice day.